And we're live.
Hi, I'm Dr. Mark Student from the Academy of Chiropractic, and I'd like to thank ChiroSecure for the opportunity to share this information with you today. And today, we're going to talk perhaps about the hottest trend in our profession, and that's chiropractic versus physical therapy for spine. Now, let's just go to the slides.
We're good.
What we're going to do is we're going to look at 5 topics, and I want to share with you that this is a very aggressive agenda for 30 minutes. But I'm going to give you a brief overview and just pieces of information. And at the end of the 30 minutes, I'm going to give you an avenue to get all of this information in a free portal to you. It's actually free to the profession, to the world, for everyone to see. The questions are, who is the best first provider for spine issues? Number two, what is the evidence? And it has to be based upon evidence. It can't be my prejudiced belief through rose colored glasses. And I'm not Pollyannish to think that those looking from the outside in aren't going to say it's a prejudicial opinion, because it really is. But when it's based upon the evidence, there is no prejudice. And the evidence is what's found in the literature that verifies that chiropractors render better treatment outcomes versus physical therapists. But what is the evidence that renders DCs having lower disability than physical therapy? What is the evidence-based physiology that drives DCs to get better outcomes versus PTs for spine as the first provider? And how do you overcome those prejudices in the medical community to bypass the PTs for the DCs to get rid of that dogma? The first thing you have to do is look at this very complicated graph. And let's break it apart, because all you need to do is count to 8. Your patient goes into an MD primary office, usually complaining of back pain, neck pain, back pain. That's it. And we'll talk about the prevalence of that within the MD primary, but it's highly prevalent. What does the MD do? They write a prescription: muscle relaxers, steroids such as a Medrol dose pack or an NSAID, painkillers, non-opiates, or opiate painkillers. And that's their first level. And I'm going to say this multiple times today: there can never be a pharmacological solution for a mechanical issue. It just doesn't exist. And therefore, you have the beginning of a failed pathway, not just treatment, but the drugs are going to fail. And I've got a tremendous amount of literature about each of these things showing how they fail. But then they're off to an orthosurgeon usually. And by the way, I will never, ever, 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 ever refer a patient to a general orthopedic surgeon for spine. They're great for shoulders, knees, hips, ankles, etc., extremities, not spine. It should be a neurosurgeon or an orthopedic spine surgeon who has done a fellowship in orthopedic spine, period. Never a general surgeon. But what happens is 8% as a rule have anatomical issues that need surgery: fracture, tumor, infection, herniation, etc., which is compressing the cord, etc. But the other 92% are mechanical issues that cannot be seen, by the MDs at least, for a surgical issue. So what do? They release those 92% to physical therapy. And physical therapist is actually an evidence-based, we're going to talk about this, failed provider as a first provider for spine. It's an evidence-based, they're going to fail. And as a rule, it fails. Then what do? They go back to their primary or back to the ortho for more drugs. And they're going to send them back for a second round of physical therapy or until their benefits run out. And it's going to fail again. But now they go back to the primary, the ortho, but now they're off to pain management. That's their final solution. Pain management is legalized drug addiction. Drug them up to shut them up because they don't know what to do. They don't know what to do. And the problem starts right here at that 92%. I am not against those patients who need surgery. I'm not against it when it's clinically indicated. But those 92% are based on dogma, not fact. Dogma is the MD's non-specific back pain. What that means is they don't know what it is. So they just send them off to PT or drug them up because medicine doesn't have a solution. I'm going to be talking in a future seminar, in a future one of these, specifically about non-specific back pain and showing, in fact, it is specific and there are tools to help you, because that dogma is based on theory, not based upon facts. But if you look at, and we're going to number this, you see number 1 through 8, we're going to start at number 1. The MD's triage, the primary care triages. In a recent study by Humphreys, Sulkowski, McIntyre, Casabet, and Patrick in 2007, in the United States, upwards of 25% of all primary care medical doctor visits are for MSK, musculoskeletal complaints, back pains, shoulder pains, etc., making it one of the most common reasons for consulting a physician. However, it's been estimated less than 5% of undergraduate and graduate medical curriculum in the United States and 2.26% in Canada medical schools is devoted to musculoskeletal medicine. 25% of their patient population and between 2 to 5% of treatment. The following results were published in this paper for the basic competency examinations of various professions in the front line of diagnosis and treatment of musculoskeletal condition. The passing in table 2, etc., the passing score was 73%. Recent medical graduates, 18%. Medical students, residents, and staff physicians, 20%. Osteopathic students, 29%. It's just incredible. They're grossly undertrained to handle MSK conditions. According to Rassi et al., they reported regarding medical providers, most respondents, 92.2%, believe that musculoskeletal education has not been sufficient. Almost every single medical doctor feels they need more. But Whedon reported that in 2013, the average annual dollars spent for back pain per person for filling opioid prescriptions were 74% lower among chiropractic recipients compared with non-chiropractic recipients. This is now tying in to the drug use. And I'm going to always compare what I'm discussing, whether it be medicine, whether it be physical therapy, et cetera, to chiropractic. So chiropractic had a 74% lowered dollar amount spent on opiates. Whedon also reported the adjusted likelihood of filling the prescription was 55% lower for chiropractic patients than non-chiropractic patients. Again, there cannot be a pharmacological solution for a mechanical problem. Something even as strong as an opiate doesn't fix the problem. Now, according to an independent research, and now we're going to number 3, the surgeon. According to independent research by myself, I've lectured to thousands and thousands of orthos, neuros, and neurosurgeons, and I always sit and chat with them. I do surveys, polls, etc. 8% of spinal cases are anatomical lesions. So if they see 100 patients a week, 8 are going to need surgery. That's it. What do they do with the other 92? Where do they go? Well, according to the Cleveland Clinic, and this is today's well-published care path for nonspecific back pain, Cleveland Clinic says these patients may be best served through a prompt access to care of a physical therapist or nurse practitioner as entry-level providers. When pain persists beyond 4 to 6 weeks, the care path defines when referral for surgery should happen, or behavioral issues, which is disgusting. The Mayo Clinic says physical therapy is the cornerstone of back pain treatment. A physical therapist can apply a variety of treatments such as heat, ultrasound, e-stim, muscle release techniques to your back and soft tissue. This is why it's a perpetual failed pathway, because they're referring them in, those 92% are going to failed pathways. Now, today we're focusing only on those 92%. And we're going to talk about capturing that market share based upon the evidence. Can you imagine getting 92% of every medical primary care referrals for back pain? We'd need 10 times the amount of chiropractors we have. Let's get into physical therapy. First, I want to say up front that I love physical therapy. I've had multiple types of practices. I've worked as a solo practitioner. I've worked with associates. I've worked in integrated practices with MDs and PTs. I love PTs. I want you to know that up front for extremity. And the duties of the delineation of the duty of care was simple. Spine went to the chiro, extremity went to the PT. Physical therapy is best suited for all rehab as the first provider, except spine. It doesn't say chiropractors aren't good for extremities. PTs are outstanding for that. However, let's look at why physical therapy fails for spine as the first provider. Let's talk about spinal competency and go back to that Humphreys paper. They also published in the paper Basic Competency Examinations, Various Professions, etc. And here, on this particular table, the following is a passing score of 70% or greater. Physical therapists, 21% on musculoskeletal care. Physical therapy at the doctoral level. By the way, the doctoral level just means they learn a lot more of what they already know. They're not going into diagnosis and triage. They're not. 26%. A chiropractic student was 64.7%. I'm a little upset about that. I think that it should have been higher, but nonetheless, compare 21 and 26% to 64%. Now, let's look at Marist College. It's a school, I believe, in upstate New York, and in its contemporary Doctor of Physical Therapy program. As far as case management goes, 3 credits in pathology, 2 credits in diagnostic imaging, including all image modalities where the emphasis on the role of imaging, not interpretation. There are 3 credits in cardiopulmonary management, 3 credits in differential diagnosis related to the proficiency of screening interview. In other words, just based upon taking a history, and that's it. The Doctor of Physical Therapy program was never intended to train PTs to be any type of primary care provider or a portal of entry into the health care system. If you look at the state of Texas as an example, in Chapter 322.1 in the statute, referral requirements for physical therapy, except as authorized by paragraph 2 of the subsection, the physical therapist is subject to discipline from the board for providing physical therapy treatment without a referral from a qualified healthcare practitioner licensed by the appropriate licensing board, who within the scope of the professional licensure is authorized to prescribe treatment of individuals. The list of qualifying referral sources include physicians, dentists, chiropractors, podiatrists, PAs, nurse practitioners. Exceptions to the referral requirement: a PT may evaluate, not treat. A PT may provide instruction to a person who is asymptomatic relating to the instructions being given without a referral to promote health, wellness, and fitness. Put them in a gym. Here's the end result. Maffey, McCarthy, and Davis and Landon in 2013 reported on medical and physical therapy back pain treatment from 1999 to 2010, representing 440 million visits, and revealed an increase in opiates of 19 to 29%, a 10% increase for low back pain with continual physical therapy referrals. They are not trained to triage. They don't understand how to diagnose. They shouldn't be the first provider. And there are universities now pushing primary spine care programs and putting physical therapy out in the forefront. It is a public health risk, and I mean that sincerely. According to Blanchett in 2016, medical care ended spinal-related compensation in medical doctor 12% longer than chiropractic, and physical therapy required 239% more time to end full compensation than chiropractic. So if someone's out on disability and compensation, according to a 2016 report, physical therapy has a 239% greater increase amount of time. Regarding partial, this is for full compensation. Partial compensation, physical therapy, 313% more time. Cifuentes reported a 32% decrease in average weekly cost of medical expenses during disability compared to physical therapy. So in other words, chiros were 32% cheaper. Maffey et al. Reported the cost of managing low back pains, not fixing anything, just managing with PT, was reached $106 billion in healthcare costs. $106 billion in healthcare costs. If we keep going, okay, Evans, and let's look at some of the reasons why, because the reasons why are critically important. Evans reported that a low velocity manipulation, PT, no matter how well it followed arthrokinematic and osteokinematic principles of intra-articular movements, will not effectuate the release of substance P. Only a chiropractic spinal adjustment with cavitation. Substance P is a polymorphic neutrophil. It's a protein that is released when you adjust your patient with cavitation. And it does things such as pain mediation, anti-inflammatory. Because what happens is it affects central sensitization. Coronado reported that a non-PT chiropractic high velocity, low amplitude adjustment caused significant changes in pain sensitivity. And when I say higher, I mean central sensitization, brain, spinal cord, in local and different spinal regions that manual therapy, PT, does not provide. Central sensitization. One of the things you have to understand is when you render that chiropractic high velocity, low amplitude adjustment, it's affecting the brain. Remember that safety pin cycle? It's not really bone, spinal cord, bone. It's bone, nerve, spinal cord, up to the spinal thalamic tract, through the thalamus, through all the different parts of the brain that ping-pongs around. Then it goes back then efferently through the thalamus, and it hits disparate areas so the body can create biomechanical homeostasis. That's the safety pin cycle. In, up, bouncing around the brain, affecting different areas, going back down, and effectuating homeostasis. There's a lot of things that happen with a high velocity, low amplitude chiropractic spinal adjustment. Now, you notice I didn't use the word manipulation. This is not a philosophical issue. PTs manipulate, osteopaths manipulate. Chiropractors render a chiropractic spinal adjustment. That argument's now off the table. Because if you start using the word manipulation, 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 again, it's not a philosophical issue. What they're going to think is you're doing arthrokinematic or osteokinematic principles of interarticular movement as those other professions do. That is not what we do. Reed et al. Found that a high velocity, by the way, here's the references, everything I'm giving you, Reed is 2014, revealed unilateral, bilateral, and multi-level hypoalgesia, pain reduction, because of central nervous system changes. Physical therapy, mobilization, and oscillation therapy has zero, nada, zilch, niet, gunish, nothing, no changes. Only a chiropractic high velocity, low amplitude thrust. Now, again, when all of that fails in the 2 rounds of drugs and PTs, you're off to pain management. Legalize drug addiction, drug them up to shut them up for the rest of their life. And I've seen it all too often. Cifuentes reported that chiropractic had a 250% decrease in disability duration of the first episode compared to the MD's care. Day et al. Reported 82% of fourth-year Harvard medical students failed the basic competency of musculoskeletal aptitude test that was reflected in inaccurate diagnoses. Devoce revealed that 87% of chiropractic patients exhibited decrease of pain verified by electrodiagnostic testing. While 82% can't even diagnose it properly, 87% of our patients are getting well. I hate this statistic. Peterson reported 69% of chronic back pain sufferers reported significant improvement in chiropractic care. My research revealed that that alone would save $110 million annually, which I think is way low. But I don't think 69% is fair. I think the number is closer to 90%, just from my own personal experience in the pits treating patient. Again, Whedon reported the adjusted likelihood of filling a prescription opiate analgesic was 55% lower. Can you imagine that? 55% lower in opiates? Why? Because they're so busy treating the effect. When we're of non-specific back pain, which is dogma, not true, because what medicine is saying, I don't know what's wrong. So let's just drug them up so we could do one of these, close our eyes to it. Drug them up to shut them up. And that is not the solution, because there can never be a pharmacological solution to a mechanical issue. And by the way, what's that mechanical issue? We're going to do a whole presentation on this. You ready? Here's what subluxation is and what the adjustment does. You have 2 bones that approximate each other. Actually, in between the bones, there's a little plica or a spacer, okay? And that little spacer, when you have a macro trauma like a car accident, sports injury, or repetitive micro trauma, that spacer dislodges. Now the bones approximate, the facets. That's your bone on nerve. It's not the nerve root. That's your bone on nerve. And then what occurs is there are nociceptors on the facets. but also in the ligament. And I'm doing a whole program on ligament physiology and neurology and pathology. But in the ligament that holds the bones, there's Pacinian corpuscles, Ruffini corpuscles, nociceptors, all the stretch and crimp receptors. And it has to do with mechanoreception and proprioception. Fires off to the lateral horn, up through the spinal thalamic tract, into the thalamus. It ping-pongs around the anterior cingulate, the prefrontal cortex, the motor cortex, sensory cortex, hypothalamus, and a few other areas, back down through the thalamus efferently, and now it affects different areas. And then what occurs is by that high velocity, low amplitude thrust, you're putting that spacer back in to keep that bone out of position. But the muscles, if it's there a long time, are conditioned to hold it in the wrong position, and it'll eventually slip back out. So you need to do chiropractic care repetitively. Now, if in fact you leave it there too long, based upon Wolff's law and the piezoelectric effect, the bone will remodel, can never fix it. But and you have to manage your case, just like a diabetic is managed, or high blood pressure is. You're not going to fix anything. You're going to keep it spaced. But if that bone is not yet remodeled, you can make a true correction that's lasting, which is why people early in life must get their spine checked to see if, in fact, this phenomena is going on with their body. I call it a pathoneurobiomechanical lesion, which is consistent with the literature. But there's been another name for it since 1895. It's called the vertebral subluxation complex. And I don't really care what you call it. Pathoneurobiomechanical lesion, stick with our historical jargon of subluxation complex in the vertebra. I don't care, but that's the mechanism, and everything I just shared with you is literature-based. Everything. Our next program is going to be a full explanation on what I just shared with you. Okay, that plica going out of position, the bones approximating. I'm going to be doing 30 full minutes on just that. Simple, simple, simple. It really is. Because remember, and here's the key, this will explain why chiropractic is the best first choice for spine. And hint, it has to do, you see this? It has to do with this. It's really, really simple. But you see, the problem is, folks, you have outcome of a perpetuating this failed care path. The outcome right now, if you follow the Mayo Clinic and the Cleveland Clinic's recommendation and the 92% that end up in physical therapist's office, you have perpetual pain leading to oxys, okay, to opioid addiction. And then Wolff's law kicks in, and then you've got a degenerative society where people are like you see in the nursing homes, just all bent over. All of those things are going to occur. Not should, not could, not might. They will. Because again, you cannot have a pharmacological solution to a mechanical issue. Have I said that enough? I want to beat it into your brain. You've got to be able to help the body create homeostasis. The body needs to be plumbed biomechanically between the glabella, the chin, episternal notch, belly button, pubic symphysis, and on the side, earlobe, shoulder, hip, plumb, AP and lateral. Because if not, the body's going to start doing this and making you bent and crooked and twisting around, so it can create homeostasis, and it'll do that through different positions of antalgia, whether it be head forward, head back, whatever it is. The body's going to always try to create homeostasis. But when it does that, it's going to put aberrant pressure on the bone. As Julius Wolff said in approximately 1859, if there's aberrant pressure on the bone's going to remodel. And if you want an example of that, if you wear glasses, take them off, run your hand behind your ear, you're going to feel a divot. The weight of the glasses remodeled those bones. That's Wolff's law. And the piezoelectric effect is the mechanism behind it, which has been known for decades, which is what creates that to occur. And that's a topic for a whole nother conversation. But that's important. Now, what we have to understand is shifting referrals. Listen, I love chiropractic. I understand that. There's a business hand and there's a service hand. We've just discussed the service hand. But how can you have a business hand if you don't understand what your service is? But you have to have that through four things, actually. Evidence, and I've given you a lot, and I'll show you where to get a lot more in just a moment. You need the demonstrative proof, and the proof comes with testing. So you need instruments that can give you demonstrative proof, not just I told you so. And we're going to give you that in a future program. But then you have to understand there's peer-to-peer case management. I've sat with so many neurosurgeons and orthopedic surgeons and neurologists. You know what they say to me? I love chiropractic care. I just haven't found a chiropractor smart enough to work with. And I mean that sincerely. And it's funny because one of my doctors in Cedar Park, Texas, Aaron Smith, who I've trained, Aaron walked into an orthopedic surgeon's office. He was in practice, I believe, 8 or 9 years at that point in time. And I spent months training him, months. He told me, Dr. Mark, I walked in, the guy gave me 5 minutes to kiss his ring. That's it. He wanted my referrals. He said, we spent over an hour and all we discussed was MRI acquisition protocols. He said, I walked out of that meeting with 150 referrals the first year because I was the smartest chiropractor he's ever spoken with, and he knew I could manage the cases. If you go in and you talk technique and theory and philosophy, you're cooked. They don't care. You don't go in and ask them their surgical. I use a double Trendelenburg super duper knife technique. They don't tell you their technique. Why are you telling them yours? You're supposed to get your patients better. They want to know if you can manage the cases. And all it takes is one thing: credentials, 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 credentials. That's it. And you need the knowledge behind them. There's programs out there such as becoming trauma care qualified, hospital qualified, advanced education and MRI interpretation, all of these different things that help you triage cases, because that's what they want. That's what the medical community wants. Lawyers want that too. Look at something else. And let's look at chiropractic as the first provider in primary spine care, and only chiropractic, not PT. Howling added, I talked about Howling before, and this is in 2015. The mean total hip, spine, and shoulder pain related healthcare costs per patient during a 4-month study were 40% lower when patients initially consulted chiropractors compared with those initially consulting MDs. The reason for this difference was a lower use of healthcare services other than first contact care in patients initially consulting DCs compared with initially consulting MDs. We got them better. We didn't need to do a zillion different things. We didn't need to image every single patient. They didn't have to go to surgeries. They didn't need 12 or 3 or 4 courses of steroids, non-steroidals, muscle relaxers, opiates. Those things are expensive. Now, the estimated total expenditure for neck and back pain between 2018 and 2027, 10 years, that we as chiropractors could save is $4.65 trillion to the healthcare delivery system based on inflation and today's statistic using this report above. Think about that. We could save $4.65 trillion to the healthcare delivery system simply by having chiropractic as the first provider. In order to understand that, you have to discover your why. And that's what we're going to do the next time we do this. You need to know why. Now, if you want research and you want all of these statistics, go to the U.S. Chiropractic Directory, uschiropracticdirectory.com. It's easy. Click on the research tab. There's hundreds of these articles, hundreds and hundreds and hundreds. And to date, we've gotten, this is probably the most visited chiropractic site in the industry. Since 2012, June, we've had 20,635,866 looks. And this is as of 3 days ago in March of 2021. But it's just incredible. I mean, chiropractic spinal adjustment manipulation versus mobilization, chiropractic home management pre and post spine. No evidence exists between chiropractic care and cervical artery dissection. There's a whole series in here on chiropractic versus PT. It's just really cool. Now, to learn more about our live programs and our consulting platforms, we have an online university with incredible courses. No basket weaving 101, I mean the real deal. Please visit the academyofchiropractic.com. Our symposiums are 2 and 3 days long. Everything is online. You don't have to travel anywhere. Those days are over. Technology is wonderful. And we do them usually in May and either November or December. So please, I urge you to come share your learning experience with us. I am humbled by those who choose to give their valuable time and hard-earned money with this. And we work very hard to earn it all and to make sure that we deliver quality content. Everything we do is for CE credits. And I look forward to sharing it with you. I am always, 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 always available. Always. So you need me, here's my cell phone number. Here's my email address. Call me anytime your heart desires. So listen, I'd like to take just a half a moment and thank ChiroSecure for offering me the opportunity to share this information with you. I love chiropractic. It's my passion. If it helps chiropractic, if you need help, I'm all in. Just call me. I'll do anything. It'll be my pleasure within my power. Our host next time, I believe, in this series is Janice Hughes. I'd like to thank you for sharing the time with me. Have a great day.